Hello there, my highly esteemed and valued viewers and listeners, and welcome back to Pharmacotherapy Consultants. My name is Dr. Nath Arwa, and I'm the founder of Progressive Pharmacotherapy Consultants, a premier virtual clinical pharmacy institute for capacity building for those working in the healthcare sector. We are the virtual clinical pharmacy institute with a difference, where patient safety, medication therapy management, and optimal treatment outcomes are very crucial and negotiable to us. Here, we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So I humbly urge you to sit back and spare me part of your precious time to share some tips with you. So welcome. So question number 1 reads, AOS is a 26-year-old graduate student who presents to the clinic today claiming he has recently had brief periods of intense fear with a rapid heart rate, chest tightness, sweating on the palms, and tremor. These episodes have occurred in several settings, and he claims at times he fears having a heart attack. And when he had an episode last evening, he rushed to the accident and emergency area, and while there, the episode spontaneously resolved. His physical examination, cardiac examination, and lab results appeared normal. The medical resident who saw him at the accident and emergency suggested he be evaluated as soon as possible by his primary physician. His current physical examinations and the ECG in the clinic today are also normal. His medical history is non-contributory, and he has no medication or food allergies recorded. When asked, AOS says he has been able to attend lectures as usual and work on his research. Given AOS's history, which medication regimen would be the most appropriate for him in your opinion? Would it be Sertraline 25 milligrams administered orally once a day, or would you recommend Bupropion 7.5 milligrams taken every 8 hours orally, or would you administer Sertraline at a higher dose of 50 milligrams once a day plus 0.25 milligrams of alprazolam administered every 8 hours, or would you settle for 6 milligrams of Olanzapine alongside 25 milligrams of fluoxetine? I'll give you 10 seconds to make the correct choice. So I would settle for Sertraline, but at a dose of 25 milligrams taken orally once a day. Now, this patient has classic signs and symptoms of what we call PD, panic disorder. Now, selective serotonin reuptake inhibitors, the SSRIs, are considered first-line agents for PD management. Bupropion isn't effective for PD, so I would knock that off the list of favorites. The combination of Olanzapine and fluoxetine is indicated only for treatment-resistant depression of bipolar depression and not PD like in the case of our patient here. Now, the next factor I would consider is whether the patient will be bridging therapy for a short-term with a short-term benzodiazepine together with the SRI or not. Now, bridging is generally only used when the patient is functionally or seriously impaired by the condition, which is PD in this case. Now, when I consider all facts, this patient claims he can still attend lectures, so he's not dysfunctional and is able to do his research. And because of this, he should only receive Sertraline. The Sertraline dose of 50, in my opinion, would be too high to begin in PD, especially if the symptoms appear so high that benzodiazepines are warranted. So I would avoid C. I would spare it for a later date. Let's move to the next question. CRD is a 47-year-old lady who presents to the clinic today with concerns of feeling sad all the time and having anxiety and insomnia and feeling hopeless most of the time, and this has gone on for like 2 months, and things appear to be turning out for the worse. She appears to be worsening. She no longer enjoys performing her regular tasks and has difficulty socializing with other people and going places. She denies suicidal plans but claims she doesn't want to live any longer. She is a career dental assistant and has continued to make herself to go to work. She doesn't go willingly, she's forced by circumstances. She scores 20 on the what we call PHQ-9. Her other medical conditions include poorly controlled hypertension, currently managed with hydrochlorothiazide alongside amlodipine. She also has a history of COPD caused by smoking, which she manages with salbutamol and serrated discus. She also has chronic low back pain treated with ibuprofen and chronic constipation, which she treats with polyethylene glycol granules dissolved in water. She currently takes an estrogen co-formulated with a progestin oral contraceptive, and she desires to reduce her smoking or quit totally because of her COPD. Her physician wishes to initiate cognitive behavioral therapy plus an antidepressant of some kind for her mood disorder. So which of the following is the most appropriate for Lady CRD at the moment? Would it be Bupropion? Would it be Sertraline? Would it be Venlafaxine or Imipramine? I'll give you 10 seconds to choose the correct option. Personally, I would settle for Bupropion. Now, this lady is having a major depressive episode. She hasn't been treated with any medication, so initial therapy would be with any of the newer antidepressants. However, most evidence-based guidelines suggest an SNRI or possibly another one of the newer agents. Now, all the medications that appear on this list except Imipramine would be possible or probable options for her treatment. Imipramine is a tricyclic antidepressant, and tricyclic antidepressants are treated as either second or third line agents in a condition like hers. Adverse effects of their use and for this particular patient would exacerbate like her constipation. Remember, somewhere in the text they've talked of her chronic constipation. A TCA would worsen that situation, so I would knock off option D. Now, Sertraline could be used, but there is a potential drug-drug interaction with ibuprofen that would lead to excessive or increased bleeding, so I would knock off option B. Bupropion could be used as first-line agent if other considerations are present, such as wanting to stop smoking. Remember, she has expressed that desire, so it would be a better option because it also helps in a smoking cessation. Now, Venlafaxine could also be used. However, she has poorly controlled blood hypertension, and as the Venlafaxine dose is increased in the course of therapy, if we opted for it, her blood pressure might become an issue. It might also be increased, so the best option would therefore be Bupropion, because she also expresses a desire to quit smoking. Let's move to the next question. PLO is a 34-year-old man with a long history of bipolar 1 disorder. He has had many episodes of acute mania and depression. He is admitted today on an involuntary 72-hour hold. He'll be held for 3 days, having been brought in by the police. Now we are told his neighbors reported him running up and down the street, shouting that aliens were coming and that everyone should take shelter. On admission, he was agitated, hyperactive, and hyperverbal, changing from one topic to another at random. During the admission, he was interviewed and he had flights of ideas. He was grandiose and he lacked insight. On entering the inpatient unit, he still spoke of the same aliens he discussed earlier, coming through the walls this time, and his agitation kind of increased. He was also yelling at fellow patients and staff in the ward, but he wasn't aggressive. So, which agent would be the most appropriate to recommend to quickly address these symptoms listed here? Would it be Lorazepam? Would it be Divalproex? Would it be lithium carbonate? Or would it be Olanzapine? I'll give you 10 seconds to choose the correct answer. So I would settle for Olanzapine. Now this patient is having a manic episode associated with bipolar 1 disorder. He has no symptoms of depression at the moment, so it is not a mixed episode. Acute agitation associated with the bipolar 1 disorder can be treated with either a benzodiazepine or a second-generation antipsychotic agent. Both are rapidly acting compared with lithium or Divalproex, which are mood stabilizers per se, that are more useful in maintenance therapy, not acutely like in our case. When deciding between a benzo and a second-generation antipsychotic, the presence of psychotic features can help make a wise decision or a good choice. This patient is clearly psychotic and is having delusions, which make Olanzapine the best option among the four. It could be given orally if he cooperates, and if he remains aggressive, an IM injection would be in order. So I would settle for answer C and administer it either intramuscularly or orally, depending on the circumstances. Let's move to the next question. So Mr. BCW is a 40-year-old man with a 10-year history of major depressive disorder. He has been taking Sertraline for 12 weeks. His depression has fully responded to therapy, except he still has problems with insomnia. He can fall asleep but wakes up around 3 a.m. in the morning and can't resume sleep from that time on. Unfortunately, he has to get up at 6 to report on duty. He tried Zopiclone without success. He reports no other medical problems, nor does he have any medication allergies. He doesn't drink alcohol, neither does he use nicotine. So which of the following would be the most appropriate agent to manage his condition at the moment? Would it be Zaleplon taken at bedtime, or would you recommend melatonin at bedtime, or would you give him trazodone at bedtime, or would your best bet will be zolpidem at bedtime? I'll give you 10 seconds to make the correct choice. Personally, I would settle for D. Now, this fellow has a sleep maintenance problem, not initiation problem. Zaleplon is most useful for problems with sleep initiation, not maintenance, so it would not be a suitable option. However, it may not last the whole night. The effect of Zaleplon may not last the entire night, so it can be given if one awakens at night, but only if there are at least several hours before one gets up. It would not favor our patient because he wakes up at 3 and has to be up by 6, so this would not be a good option. Although melatonin and trazodone are often used, evidence of the effectiveness is limited for pharmacologic treatment of insomnia according to the guidelines that are available currently. Now, zolpidem is a longer acting agent, and current guidelines suggest its usefulness for both initiation and sleep maintenance. So this one would serve our dear client better than the rest of the drugs listed there. Let's move to the next question. So AJO is a 15-year-old adolescent boy with the newly diagnosed attention deficit hyperactive disorder, ADHD. It was diagnosed 4 months ago. He was initiated on methylphenidate extended release, taken an hour before reporting to school, which he has tolerated well, and the dosage has been titrated to the maximum dose. Now, although he has tolerated it well, measures of inattention and hyperactivity showed that it was only modestly effective in this fellow. In particular, in school, he has continued to have inattention throughout the day, which negatively affected his academic performance. Now, this boy is in the clinic today for evaluation of his medication regimen. So, which would be the most appropriate recommendation that you'd make with regard to AJO's treatment? Would you recommend he continues with methylphenidate and add guanfacine, or would you discontinue the methylphenidate totally and initiate Bupropion, or would you continue the medication and add Quetiapine in addition to it, or would you discontinue it and initiate a mixed amphetamine salt? I'll give you 10 seconds to choose the correct answer. Opt for D. Stimulants are the most effective agents for the broad spectrum of ADHD symptoms. Now, this boy is tolerating methylphenidate well. However, it's only modestly effective for his condition. Trying another single agent, e.g. a mixed amphetamine salts, would be preferred to combination therapy. And guanfacine is an effective agent, but it is second line, not first line. It is second line to stimulants and is more effective for hyperactive and disruptive behaviors than for attention. And for him, attention will also be very key if he is to perform well in his academics. Similarly, although Bupropion isn't approved for ADHD, it can be effective as second or third line. So in this case, I would opt for the mixed amphetamine salts Second generation antipsychotics like the Quetiapine are commonly prescribed for ADHD, but they aren't considered for routine treatment and should be discouraged unless some other comorbidity justifies their use. And most evidence-based guidelines recommend at least 2 trials of monotherapy with stimulants. Now, failure of one of them doesn't predict failure of another. Thus, changing to a mixed amphetamine salt, which is marketed as Adderall, would be the best course of action for this particular patient. Before we go to combination therapy as quoted in other cases, I would settle for D for this particular young man. Let's move to the next question. So Madam JHJ is a 39-year-old woman with a long history of substance use disorder. Her preferred substance is hydrocodone, co-formulated with acetaminophen. She has obtained it illicitly on the streets in the past and currently has different prescribers prescribing it for her. She plays tricks on them, and none of whom has checked the national database on prescriptions for controlled substances. She was recently fired by her employer and has defaulted with the payment of her mortgage because she is jobless. She has reported to the treatment center for an evaluation for potential entry into the buprenorphine maintenance program. She was medically cleared for treatment, and today she presents for initiation of therapy. She denies recent use of hydrocodone, and on examination her vital signs are normal, as is the rest of our physical examinations. So which is the most appropriate recommendation for initiation or initiating buprenorphine maintenance therapy in the clinic today? Would it be delay initiation of therapy because of the absence of withdrawal symptoms and obtain a urine drug screen from her? Or would you begin an induction dose of buprenorphine and obtain a urine drug screen? Or would you begin induction dose of buprenorphine co-formulated with naloxone and obtain a urine drug test? Or would you finally begin subdermal implantation therapy of buprenorphine after 3 days of sublingual tolerability is established? I'll give you 10 seconds to make the correct choice. So I would settle for answer or option A. Now, this lady appears to be a candidate for long-term maintenance therapy with buprenorphine. Patients are brought to the clinic for induction therapy on day 1, and this is normally done with buprenorphine co-formulated with naloxone, unless they are able or they have been using a long-term acting substance, e.g. methadone, in which case buprenorphine alone is preferred for induction. However, it is important not to induce patients who do not have at least mild, if not moderate, signs and symptoms of opiate withdrawal. Now, this lady's lack of symptoms may indicate that she has taken hydrocodone within the past few hours to 1 day at least. Now, in using in this kind of setting would be risky. It incurs a risk of an opioid overdose. Now, this lady should be denied induction on this day, in my opinion, and instead you should cancel her about abstaining before you induce. And a urine drug screen may also be suggested to confirm whether she actually took opioids before coming or not, though it may still be positive even if she hasn't used it within the past 24 to 48 hours. A product called Bupropion is an implantable formulation of buprenorphine for long-term maintenance use. However, it is only used once a patient has been on sublingual treatment, not as initial therapy. So that leaves us with the A as the most ideal choice. Let's move to the next question, where a 25-year-old student comes to the clinic and says that during exams she has anxiety, difficulty concentration, she experiences tremors, and her heart revs, and she develops sweaty palms. When questioned, she states that these symptoms occur in almost all groups of situations, but tend to be worse during exam time. Additionally, she claims that these symptoms are really pronounced when she has to make an oral presentation before her fellow students in class. She denies depression or any other physical symptoms or fears of disastrous consequences or events, and she states that she is interested in both medication and psychological therapies to resolve her nagging problem. So which of the following medications listed below would be the most appropriate for her condition? Would it be Sertraline? Would it be Mirtazapine? Would it be Quetiapine or Pregabalin? I'll give you 10 seconds to choose the correct answer. Settle for A. Now, these symptoms are most consistent with social anxiety disorder, what we abbreviate as SAD. Panic disorders aren't likely because these symptoms are primarily associated with group or performance situations. Now, the first line agents according to evidence-based treatment guidelines are SSRIs or Venlafaxine. Now, Sertraline would be a reasonable first line choice for this particular lady. Mirtazapine doesn't have a strong evidence of efficacy for SAD, and Pregabalin has evidence of efficacy, but it isn't as strong as that of SSRIs or even Venlafaxine. And Pregabalin is generally considered as after first line agents have failed treatment. Now, Quetiapine has also been used, but lack of strong evidence of efficacy and concerns over long-term adverse drug effects generally limit its use to patients for whom the other first line and second line agents have failed treatment. So I would opt for Sertraline instead of the other three. Let's move to the next question, where there is this 44-year-old man who is seen at the clinic today for concerns of depression. He has a major depressive, he has had that depressive disorder for 16 years. His current episode began 12 weeks ago, at which time he was put on fluoxetine, and it has been gradually titrated to a dose of 40 milligrams a day. It has produced partial response, so further dose increments weren't tolerated by this young man, and the regimen had to be switched to duloxetine. His duloxetine dose was successfully increased to 90 milligrams a day, and it produced a 50% reduction in his depression score on the Patient Health Questionnaire 9 scale, the so-called PHQ-9 scale. Now his current PHQ-9 score is 12. He tolerated 90 milligrams daily, but not a higher dose. His provider is now considering augmenting his duloxetine therapy. Now the patient's other medical conditions include epilepsy, which he treats with carbamazepine and lamotrigine. There is hypertension, which he treats with the lisinopril and hydrochlorothiazide, and there is chronic constipation, which he treats with Senna or Docusate interchangeably. So, which medication is the most appropriate to use as augmentation therapy for this man's depression? Do you opt for lithium carbonate, aripiprazole, imipramine, or bupropion? I'll give you 10 seconds to choose the correct answer. Personally, go for aripiprazole. Partial responses for antidepressants can be treated by changing to another antidepressant. It's a general principle. Or you can do so by adding another antidepressant or using another augmenting agent, such as a second generation antipsychotic, lithium carbonate, or bupropion, or even thyroid hormone can work in some circumstances. Now this particular patient has had partial response to 2 antidepressants from different classes, with duloxetine being tolerated at the current dose. It is therefore reasonable to add another agent. All agents listed have evidence of efficacy when used as augmentation agents. However, interactions with the patient's medical conditions could limit the use of some of them. If you look at his medications list, both hydrochlorothiazide and lisinopril can reduce the elimination of option A, which is lithium carbonate, and that can lead to an increase in the risks of the adverse effects it causes. So I would knock off lithium carbonate, and imipramine, because of its side effects, can complicate the constipation that challenges this fellow. So I would also knock off option C. Now bupropion, in my opinion, is contraindicated because of his epilepsy. So aripiprazole is approved for augmentation of antidepressants and is unlikely to interact with any of his medications. So I would feel more comfortable adding aripiprazole to this gentleman's list of medications. My highly esteemed and treasured viewers and listeners, that brings us to the end of part 16 of our Pharmacotherapy MCQs series. I highly appreciate the fact that you made time and sacrifice to listen to and view this video. And if this video helped you in any way, I would like to urge you to remember to give it a thumbs up, to like it, and if you haven't, remember to subscribe to my YouTube channel. I would like to promise you that the best is yet to come, and thank you for your continued support and partnership. I hope to interact with you in part 17 of our series. Thank you for viewing and for watching.